Good evening and welcome. I'm so excited to be here with all of you. We're here tonight to talk about BHRT, but before we get started, let's have everybody just put in the chat where they're from this evening, or this afternoon, or this morning, depending on where you're from. That's why we do this. We've got Texas, Salt Lake, Ontario. Wow, it's going really fast. Ottawa, Seattle, Colorado, England, Montana, Florida. Wow, we've got people from all over the place here. Very exciting. So the next thing I'm curious about, well, actually, no, that's going to be a poll question, so I'll wait on that. Please do fill out the poll questions for us, and hopefully you've downloaded the app, those of you who have done your DNA 360 report. The app is a really easy way to go straight to the hormone section, and that way, when I'm mentioning genes, you can follow along with your own app. If you don't have the app yet, please download it. Otherwise, you'll want to look in your hormone report of your DNA 360. So, oh, in Arkansas too. I haven't seen in Arkansas much lately. Okay, so we are here this evening to talk about BHRT because so many people are talking about BHRT. And some people out there will say everyone can go on BHRT, and some people are saying no one should go on HRT at all. So it gets very confusing. There's a lot of mixed messaging about which hormones are most important, who can take them and who can't. And the bottom line is that there are a lot of women who aren't feeling great during perimenopause and menopause, and they need to know what's going on so that they can be helped, because no one needs to suffer needlessly. So tonight we're going to go into some myths around BHRT. We're going to talk about the differences between BHRT and more synthetic or conventional HRT. And we're going to talk about how your genes interact with those things, that for the good or for the not so good, and how you can use your genes to help you decide whether or not BHRT might be right for you. Well, I'm not going to be giving you direct medical advice because that's up to you and your physician. We're going to go over the general things around that. So first, I would like to see who's here in terms of what the poll questions say. So Vanny, if you could please put up the poll questions, we'll take a look. Okay. Our first question was, have you ever been offered or considered hormone replacement therapy? And 51% of our audience says, yes, I'm currently using BHRT. 27% have considered it but are unsure. 14% say not yet, they're just curious. And 7% say, yes, they've used conventional hormone replacement therapy. Question number 2, what is your biggest question about BHRT? And 34% are wondering, 40% are wondering, is it safe? 10% are wondering, does it really work? 33%, how do I know if I need it? And 17% want to know, what's the difference between BHRT and regular HRT? Question number 3 is, how familiar are you with functional genomics or DNA-based personalization? 43% of you are very familiar with it. 39% have heard of it but aren't sure how it applies to this topic. And 18% are completely new to it. So welcome to the newbies, and welcome back to those of you who come and see us all the time on these webinars. Question number 4, which of these symptoms has affected you most in midlife? The biggest one was all of the above. So that was 31% of you are having fatigue or low energy, mood changes or brain fog, weight or body composition shifts, and hot flashes or night sweats. But what's interesting is that only 11% of you said hot flashes or night sweats as your primary symptom, when that's the one that's most talked about, right? It's the fatigue and the mood changes and the body composition and just generally not feeling like yourself doesn't get talked about nearly as much as hot flashes. So it's interesting that that was the lowest statistically. And number 5 is, if you could optimize one area of your health through personalized hormones, what would it be? And 10% of you said mental clarity and mood. 23% said energy and vitality. 8% said libido and confidence. 18% said sleep and recovery. And 42% said long-term healthy aging. Thank you so much for participating in our poll this evening. So let's talk about what bioidentical means versus not bioidentical, and what forms that can take. So when something is bioidentical in the hormone world, it means that it's the same in terms of chemistry as what you make inside your body. So even though it's made from a plant, it registers in your body like the same thing that you've been making your whole life, and that's what makes it bioidentical. Having it be molecularly more similar to what your body makes can make it a little bit more easy to tolerate than anyone who was on the birth control pill and may have had negative side effects because of the synthetic hormones. They don't tend to have the same issues when they go on bioidenticals in perimenopause and menopause. Now you don't have to go to a compounding pharmacy in order to get bioidentical hormones, because some of them you can get from your local CVS or Walgreens if you want to, and if your doctor will prescribe them for you. The patches that are estradiol, that's bioidentical, and oral micronized progesterone is also bioidentical. So you can go to a compounder if you don't want some of the other things that are in the pharmacy versions of them, but you don't have to do that. Your insurance will, in fact, cover it if you have insurance, to go on bioidenticals that you can get from the drugstore. Now, I'm not going to demonize more conventional or synthetic hormones. I'm just going to say that they're not the same as what your body makes, and more people have side effects with them. So that's the sort of the deal. BHRT can, as I said, come in creams, capsules, patches, and it's estrogen, progesterone, and some women will even take testosterone, and certainly men take testosterone later in life as well. Okay, so there are a bunch of things that are said about BHRT, and some of they're true to varying degrees, right? Social media and things like that can tend to portray things in certain lights, and that's not a bad thing, because up until recently, no one was taking these things because of a study that came out that wasn't particularly well done or well reported on. So there was a generation of women who took HRT, and then there was a 20-year period, more or less, where people didn't have access to them because we thought that they were bad. So now that is all changing, and in some cases it goes too far in the other direction because they're not exactly right for everyone. Although with knowledge of your genetics, you can determine whether or not they're right for you. And if you have a tendency to clear them down a pathway that's not ideal, there are things that can be done around that. So that's the good news. So bioidentical doesn't mean there is no risk whatsoever with them. Some people can still end up with estrogen toxicity depending on their genetics, which can be really inflammatory. And if you have low estrogen, that doesn't necessarily mean that adding it without making sure clearance is okay is the right thing to do. A lot of people who first felt better right after menopause, they may have been a little bit estrogen toxic when they were younger, and then they feel better, and then they feel worse. So that's a trend that sometimes people see. And BHRT doesn't reverse it back to a time when you were 20. It's just going to help with balancing out the extreme deficiency of having your hormones decrease pretty rapidly. So one of the differences that's interesting in the way that the hormones decrease is that they typically do it in a certain order, which is progesterone, estrogen, testosterone. And what that means is that throughout perimenopause, you can end up in a relative state of estrogen dominance and testosterone dominance relative to progesterone. Even if you have low levels of estrogen, you can still be estrogen dominant. And then when estrogen and progesterone are both low, you can end up in a relative state of testosterone um, dominance, which can have its own separate side effects to it. So um, it's about the balance of all three, not about one being bad or one being good. And I do see that sometimes in social media where someone's in more of an estrogen camp or a progesterone camp. And I keep track of all of these things so that I can kind of help my patients to understand what's true about what's being said and what's not true about what's being said. Um, and there's the other thing is that BHRT will completely reverse aging. It can definitely improve energy and skin and bone health and body composition and all of those things. But once again, you're not going to look like you did when you were 20. It's just not how the world works, unfortunately. Otherwise, I mean, I would still look like I was 20. Um, and the fact that it's natural, meaning it's safe for everyone, and just because it's natural, it may be better for many people than the synthetic, but it doesn't mean that you shouldn't still evaluate whether or not it's right for you with a physician. All right. So please remember that if you have any questions, make sure that you put them in the Q&A section. So can you put a 1 in the chat if you have heard somewhere, either from a friend or social media or from someone else, that everyone should either take hormones or not take hormones? Just stick a 1 in the chat. Yeah, that's what I thought. Lots of 1s showing up. Yep. So the issue that I have when people make really strong statements about everyone or no one is that I believe in individualized medicine. And so I think it's more about educating people about what's best for them and letting them make the decision that's best for them. So, yeah, so thank all of you for participating in my little mini poll there. So, what do studies say about bioidentical hormones? You may wonder, um, and about other things that can go along with them. So, many of the more recent studies are showing that BHRT can reduce all hot flashes, is helpful for slowing down when bone breaks down. And that if you combine that with strength training, which actually builds, that you can at least slow down, if not halt, bone loss, which I think is a really big deal. That's why I'm mentioning it kind of first, because falling later on in life is a major problem. So if we can stop that in its tracks by using some hormones, then that's really preserving the health span. We're not talking about lifespan, we're talking about how long people can do things, how long they can not have a broken bone totally take them out and have them not get up again, right? So that's a really huge thing. But strength training is also really important. And the other interesting thing, I wasn't really looking for this, but I found it anyway, was that strength training actually helps reduce hot flashes. There was a meta-analysis done, and these people were also taking hormones, but the strength training, in addition to it, the people had more of a reduction in hot flashes for if they were strength training. And I thought that was really cool. Because here at the DNA Company, we also believe in the things that you can control, like what you're eating, your exercise, what you're exposed to in your life, your stress levels, all having an effect on health. So things aren't happening in this sort of by themselves thing where hormones are going to fix everything. It's more like you take hormones and you do the strength training and you make sure your sleep is good and you avoid the toxins in our environment and you eat really well for your genetic type, and you'll feel great, right? That's the sort of our thing here. So the other and so then there's mood stuff and sleep stuff. And progesterone can be a really big one for sleep because it converts into something when taken orally that helps with sleep. So it actually impacts the GABA receptors in the brain, if any of you are familiar with those, and that does cause drowsiness. And even in terms of sleep apnea, estrogen and progesterone have an effect on on the throat and the airway. So these are big things, between the temperature and sleep apnea and all of these things. If the hormones can help with um, alleviating some of these side effects, people will feel better in the morning because they've slept better, because they're cooler and they're not having their breathing stop during their sleep. And also, a 2025 review, in summary, says that estrogen therapy improves blood lipid metabolism, lowering LDL and raising HDL cholesterol, reducing the risk of atherosclerosis and related cardiovascular events. So, these are all studies that have been pretty recent. That's 2025. And I think it's important to look at those. There are some people who are still looking at that study from 20 years ago that wasn't even done with bioidenticals, and saying, oh, there's danger here. Women are going to get sick if they're taking these. And that just is not what the current evidence is suggesting. So, how do you know if you need to do BHRT? I just need a sip of water really quickly. I'm used to having a co-host, so I get to take little sips of water without anyone noticing. So what are some symptoms other than what we've already gone over? We've gone over the hot flashes, some mood things, which can look like depression. It can look like irritability. It can actually look like rage. Somebody who has been totally calm, cool, and collected their whole life suddenly is like, I'm feeling rage that I've never felt before, and they don't understand where it's coming from. There can be aching in the joints. There can be muscle pain. Definitely the low energy, sleep issues, anxiety can go up. Um, all, and then with the anxiety can come more sleeplessness and more thinking about things and not being able to let them go. And those were all, yes, headaches and migraines I'm seeing in the chat. Are there any other symptoms that I haven't listed that any of you would like to throw in the chat? Anything that you have experienced for yourself that I have severe brain fog? Yep. Anything else? Oh, yes, of course. Right. Sexual dysfunction, dryness, gut issues, atrophy, vaginal atrophy, dry, itchy skin, and there can be eye dryness as well. Yeah. So, yeah. See, I needed the audience's help. And then racing mind in the middle of the night, right? All of these things can be related. Anxiety, tearing up more than usual. Yes. Yes. These are all, and a lack of motivation. Yes, like the kind of the get up and go and the excitement, and dry mouth, yet dryness kind of anywhere, and itchy ear canals. I have heard that one before, rosacea. And, that can also play, can be impacted by some of the genetics, sore shoulders. Yeah, I'm sorry, ladies. I hope you're all feeling better really, really soon. So if you're experiencing all of those things, then it might be time to talk to your physician or someone about whether or not BHRT is right for you. And then when you go to the doctor, how do you know for sure that that's what it is? How do you know that it's not some other condition and then you don't want to be taking hormones if you don't need them? Well, there is a lot of testing that can be done, right? So you can do blood testing to see what your hormone levels are. And you can do Dutch testing to see what your hormone levels are and how you're metabolizing them. Both of those things are one snapshot in time. So it can depend on time of day. It can depend on the time of the month. If you're not cycling anymore, it can be really hard to know when to do the tests because you're still going to have some fluctuation, but you don't know exactly what that means. And that's true if someone's had an ablation. Also, you can also do mirror testing. And mirror, you test more throughout the month and you can kind of see things going up and down. You can see whether you're ovulating anymore. You can see what there are some hormones that will go up as you get closer to menopause and some that will go down. So typically, FSH, follicle stimulating hormone, and LH, luteinizing hormone, will go up, and things like progesterone and estrogen will come down. And the only one of those tests, that test does not test for testosterone or androgens, but the Dutch test and blood tests both will. So you can get this testing done and see where you are, and then you can assess, is this a hormonal issue, or it could be something else and still the hormones are impacting it? Because what I have seen over and over again is that perimenopause and menopause make everything worse. So if you have arthritis, it'll make it worse. If you have an autoimmune disease, it'll make it worse. So it's just dealing with the hormone aspect of it, even if it's not the primary thing that you've been dealing with for years and years, it still can be helpful in that it may not get worse. So you also would want to check your genes and also make sure that your digestion is good. There are certain kinds of bacteria in the gut that will increase levels of something called beta glucuronidase. And this is an enzyme, and it's there to kind of help recycle some things so that they come back into the body. And one of those things is estrogen. So if your gut microbiome isn't functioning properly, and this enzyme goes up, you can actually, instead of clearing estrogen, you can just bring it back into the body, and you can end up with estrogen dominance and or toxicity. There are things that can be done about it. You can take calcium D-glucarate, for instance, and that will lower levels of that. But you don't just want to go out and take that if you're not feeling well without knowing what's going on. And here's why. This enzyme is also part of what helps us to keep vitamin D and some other fat-soluble vitamins in your system. So you don't want to be taking vitamin D, taking calcium D-glucarate, not really needing to work on your estrogen levels, and just having your vitamin D go back out more quickly than it should. So you would want to get a gut test in order to see if that's what's happening. I just want you to be aware. If your stomach, if your digestion isn't what it used to be and you're feeling like that's an issue, that could also be impacting your hormones, right? So, and fiber is good for that. But just if you're having a symptom, just get it checked out. See why is my digestion off? Why is it worse than it used to be? These are all good questions to be asking yourself and your practitioners. And then you also want to make sure that then if you do start taking hormones, that they are in a certain kind of balance. You don't want to have so much, and estrogen and progesterone, for instance, they work together, but they also work in opposition. So you don't want to have too much estrogen and you don't want to have too much progesterone, because otherwise each of them isn't going to do their job in your body properly. So you would want to get tested before going on BHRT, and then again after you've been on it for a few months, just to make sure that all of your levels are balanced. So genetics, right? I know that's why you're on our webinar about HRT, right? Is because we have this special way of looking at things, which is through a genetic lens. So some of the first genes that we think about when we think about hormone balance are some of the CYP genes. So if you're looking at your app, and if you haven't downloaded the app, please download the app. And let's take a look at CYP17A1. And this one, you convert progesterone into testosterone, sometimes more quickly, sometimes less quickly, sometimes in a balanced way. And if you are someone who has an increased conversion of progesterone into testosterone, two of the things that might happen are, one, you may notice your symptoms of progesterone going down sooner than someone else. It may be at a slightly younger age, and that can look like irregular cycles. You might start bleeding every 24 or 23 days out of your cycle instead of going longer into your cycle. You might start to notice sleep issues creeping in. You might start to get more migraines as you get into perimenopause. Those can all be symptoms of that. And then also, you might notice that you're having more symptoms of having a lot of androgens as you get into perimenopause and menopause. And sometimes I'll look at someone's Dutch test and they have testosterone levels that are in the premenopausal range when both progesterone and estrogen are both in the postmenopausal range. And they're having symptoms like their hair might be falling out, but growing in other places that they don't really want it to. They might be having a certain kind of look to their belly and they're like, what's going on? Why is this happening to me? Or they might be having more irritability. So all of those things can kind of happen, not just from this one gene. I'm just sort of telling you a story and incorporating the genes that can be part of it into it, because we never look at just one gene. We're looking at the whole family of genes, the entire metabolic pathway. All of these genes are working they're in your body, they're working together, and they're part of what makes you unique. Two people are not going to have the same pattern. And so that's why it's really smart to look at all of them. Then SRD5A2 is another one that would be involved with testosterone. And that's about conversion of testosterone to DHT, which is a lot stronger. So if you have an increased conversion in CYP17A1 and increased conversion in SRD5A2, you may notice all of the things that I just mentioned, but it might be a little bit more quickly because that DHT is pretty strong stuff. But then maybe you're someone who clears it out more quickly. So if your UGT 2B17 is fast, this can either you might have lower testosterone earlier than someone else, or you might be clearing it and keeping up with your genes that convert it more, or you might convert at a normal rate and have decreased metabolism. There are all kinds of ways that this can look, but this is part of what is going to factor into it's about making it and converting it, but then it's also about what clears it. So this is one of two genes that does that. And the other one is UGT2B15. So looking at those are all about clearance of androgens. So the next genes that you might want to take a gander at are CYP19A1. And this one is about converting testosterone into estrogen. So it's about aromatase. Once again, anything with an A's, that tells you that it's an enzyme. And if you are someone who converts it into a lot of estrogen, then, you may end up with looking more curvy. You you might not. It depends what your other genes are, but you may end up with more of an estrogen dominant look. So in your genetic reports, it might say something like you're estrogen dominant, you're androgen dominant, or you're co-dominant. So just so that you know that these are some of the possibilities. Some things are just a little bit more balanced than others, but you may have genes that balance out one of the ones that I mentioned because of how things are cleared. The next gene that I want you to take a look at is CYP1A1, and this is part of the metabolism of estrogen. And so estrogen gets metabolized, and it, depending on your genetics, it has more or less of a tendency to get cleared in different pathways. It's sort of like if you want to go to the store and you know that there are 3 different roads that you can take to get there. One of them might have less traffic than the other one. And if you pick the right one on that day, awesome, you're psyched. And if you pick the wrong one, you're going to get there a little bit more slowly. And so we have these three main things that estrogen can get converted into. And CYP1A1 is about 2-OH. And 2-hydroxyestrogen, or estradiol, is the more preferred pathway. Like it's the one that GPS is like, you've got less traffic. This is the way we want to go. So some of you are going to have increased metabolism into 2OH. Some of you are going to have decreased metabolism into 2OH, which is technically considered less ideal, but don't worry, it's okay. Even if that's the case, it doesn't mean that you can't live a perfectly wonderful life or that you can't take HRT. You will just have to, depending on your other genes, you may have to do some supplementing and eating a certain way in order to make that okay for you. Then we have CYP1B1. So the first one was CYP A1. This one's CYP1B1. And this is about metabolism into 4OH. So you will see that if you have an increased metabolism into 4OH, that it says that that's suboptimal. And that's because this can be an inflammatory path for it to take, right? You've got all the angry drivers on this road. So it's sort of inflammatory. And so we would want you to do things that would convert down the other pathway. It is something to keep in mind when you are considering HRT is how you're clearing estrogen. Once again, this does not mean that you are ineligible for BHRT if this is your preferred pathway. It just means that you want to talk to someone who knows how to make it less risky. Then we have CYP3A4, and this one is about metabolism into 16OH, which is also an inflammatory pathway. So once again, if this is your preferred path, and sometimes you can have two or three. I mean, you can have genes that say, you're preferring to go down two different roads at the same time. And you think, how is that possible? But in this case, it is. And so if you have an increase in this, once again, this is going to be where you want to do something if you decide that you're going to take estrogen, just to make sure that it's being metabolized in a better way. And then we have COMT, our good friend. I feel like we talk about COMT all the time. And if you have a slower COMT, then that's another place where estrogen as a whole might be metabolized more slowly. And because of the fact that it also breaks down dopamine and norepinephrine, this is also where stress can really mess up your hormones. I shouldn't say mess up, can really impact your hormones in a perhaps negative way. If you are having a lot of stress and you've noticed, when that happens, I'm getting feeling bloated and kind of headachy, and I can feel the inflammation, like my hands get a little swollen, things like that. I think I already said headaches. And then when you're not stressed out, it's better. And if you have a slow COMT, that's not a surprise, because the stress hormones, especially if you have a couple of deletions in ADRA2B, the COMT gene may be trying really hard, having all of the enzyme kind of go in that direction, right? And instead of it being balanced throughout other things like estrogen, and this gene also helps break down quercetin and a bunch of other things in plants. So sometimes when we're stressed out, we're like, oh, my immune system's not going to be great, so I better take all these supplements. But then if COMT is part of breaking those down, it may be doing you not any favors to do that. So knowing your genetics is just so important when you're dealing with hormones and when you're dealing with stress. And then I want to go down on my spreadsheet, that is. There's one more gene that I didn't mention that has to do with androgens. And it always hides from me. There it is. Androx or AndroX. And that's probably also that should also be in your hormone report. And that's about binding. So this is about how muscle mass can really be impacted by this, because you can have a lot of testosterone, but if it's not actually binding, it might be harder for you to do things to use it. So, for instance, to use it for things like building muscle. Um, when it's not binding, what is it binding to? So some people notice that if they have a certain gene presentation, that they will have higher levels of SHBG. And so that's just an interesting thing to note because that's also something that can be tested for in blood. So um, put a 1 in the chat if you feel like um, hearing that stuff about your genes has helped you to understand a little bit more about estrogen metabolism and when it might be a good idea to um, take action if you decide to go on HRT. Okay. Okay, good. By and large, yeah, I know I do talk fast sometimes. The good thing is there will be a replay so you can watch it over again. And also, you can make an appointment with one of our clinicians and they can go over it with you. I'm going through it fairly quickly because I only have 20 more minutes to get through what I need to talk about before the Q&A. So I do apologize for speaking quickly, but by and large, most of you seem to feel that it was helpful in terms of figuring it out. So if I were to summarize, what I would say is this: figuring out your tendency to convert and be able to get rid of. When I say metabolize, I mean put it into the next phase of what it needs to be in order to be taken out of the body. Because we don't just want to make these things and take these things and just have them build up and up and up in the body, right? There's a process of breaking it down and excreting it. And if you're not doing that in an ideal way, then that's when you can have some issues where you don't feel great on BHRT. So some people take it and they feel awesome and they're like, this changed my life. I will never go off of this. This is amazing. And some people are like, you know, I started to have this symptom or that symptom. And a lot of that has to do with how you're getting it out of your body. So it's your personal interaction with the hormones. And that's where your genetics can really guide you in a direction of uh, knowing how much support you need if you're going to take BHRT. Okay. And we did talk about the gut biome, microbiome also being really important here. So this is why, your friend down the road can have a completely different experience of menopause and perimenopause than you do, is because of the genetics. And for some people, it will start earlier. For some people, it will feel worse. And for some, it's the same thing with taking BHRT. Some people respond really well to it. Some people are like, I'm taking the same dose as my buddy, but it's not really doing it. You might be clearing it really fast. And so that's why testing and not guessing, both for your genes and for what your levels are once you start taking it, is really, really important. Okay. Whew. I do talk fast sometimes. So in terms of longevity, which I know was a piece of what some of you were interested in, the reason that people are associating BHRT with longevity is because of the cardiac, bone, brain effects of this. There are a lot of cardiac issues that suddenly seem to happen to women around the time of menopause. And studies are showing that estrogen is a big piece of that. So when people start taking it, if they can halt the progression of some of the things that change during menopause, then that helps cardiac health. And all the dryness that's going on, that also is a hormonal thing. And so in terms of like how you look, that can really make a big impact. And also, no one wants their sex life to just sort of fizzle out. I shouldn't say no one wants that. If you do want that, that's cool. That's totally your prerogative. Many people do not. We want people to have a choice. And so if that's happening for you because of pain during intercourse, because of atrophy, because of dryness, even just doing local hormones to try and help that, it also helps with urinary health. When older people get a lot of UTIs, estrogen, just a very, very low dose, can be a total game changer for them. So there's, if you think about it, we have receptors for these hormones everywhere in our spines, in our brains, in our muscles, in our skin, all over the place. So it's not just about things from the waist down that get affected. It's really our whole bodies. And that's why the brain fog happens, is because there is an effect that these hormones have on our brains. And when women take them, they find that they feel better they don't have as much brain fog. And while everyone does respond individually, if you're feeling sharp in your brain, if you're feeling like you can have sex if you want to without it being painful or unsatisfying, if you aren't worried about your bones breaking and your heart is staying in better shape, people tend to feel younger. And also the energy levels that can come back. And when people feel younger, they tend to look younger. And when your heart and your bones stay in good shape and your brain, that's longevity, right? That's probably the three most important, one could argue, things that go wrong as we age tend to be brain health, cardiac health, and falls or not being able to move. So that's how this relates to longevity very specifically. I am seeing so many questions in the Q&A. I think I'm going to start answering questions in the Q&A a little bit early because I do want to answer your questions. So I'm just going to take a sip of water and then I'm going to get started on your questions, okay? And I have had one quick thing before I do that. I have had multiple patients get diagnosed with various problems as they were in perimenopause and menopause. And then suddenly they went on hormones and things just started, their diagnoses started disappearing and they stopped taking medications. And you should always stay on medications unless you're coming off of them with your doctor who prescribed them, just to be really clear about that. But the difference in how people felt, because sometimes they would start to take one medication because they had a diagnosis of something, and then they would have a side effect. So then they'd have to take another one and so on and so on. And I'm not against taking medications when people need them. And hormones are a medication, right? But things can get misdiagnosed during this time period. And they can be hormone issues. And if someone would just test for that, it could really make a difference in people's lives. So I've seen that over and over again in the the 20 years that I've been practicing. So, all right, let's get this Q&A going. Okay. All right. So the first question from Lynn is, I currently take progesterone and DHEA, but not estrogen. I did take estrogen transdermal cream for several months, but I didn't notice anything, so went off of it. Can I stay off of it if it didn't make a difference? So I would definitely encourage you to talk to whoever prescribed it about this. But if the question is it dangerous to take progesterone and DHEA without estrogen? You really want the balance. So I would get a blood test and just make sure that your numbers are in the right range for it. Sometimes people don't notice as much of a difference with one hormone or another, but it doesn't necessarily mean that you don't need it. It just means that you are more sensitive to the deficiency of one of them than to the other. And I don't know your age or anything else about your health history. And I'm not the person who is recommending these things to you. So I would say talk to them about it, let them know that you made that decision, and just get a test done and see how things are. But there it is not recommended that people take estrogen if they have a uterus without taking progesterone. It's not the same thing in the reverse. Like there aren't studies showing that that it's dangerous per se, but I just believe in balance. So that's my answer to that question. But I will say that if you have not had a hysterectomy, and you do still have your uterus, that there's a certain number of days at a certain dosage that you must take progesterone with your estrogen if you're going to go on hormone replacement therapy. It's also possible that you're converting some of these other things through a pathway into estrogen already, and that's why you didn't notice that much of a difference when you started taking it. Okay. Next question. The only symptom I have is vaginal atrophy. Why isn't it on the list of symptoms? That's a really good question. It just didn't spring into my mind immediately, but it is in the list of symptoms, 100%. And that's, it's not just painful necessarily during intercourse. It can just make having a vagina more painful. And so, I apologize for not listing that immediately as one of them, because it's definitely a big deal. Okay. Then we have Barb. What do you think if someone has had a hysterectomy, don't they lose all the 3 hormones together at one time, as opposed to someone who naturally ages? So yes, so the short answer is yes, if you don't have ovaries anymore, which not every hysterectomy do you not end up with ovaries. But yes, then you definitely are looking at more of a drastic decline in all 3 hormones. And you can make, our bodies make some hormones in our adrenals and in other tissues. For instance, our fat tissues can make some estrogen for us, and our adrenal glands can make some androgens for us. But it's definitely not going to be at the level of someone who has their ovaries and is currently cycling. Now, it also depends when you have the hysterectomy. If you have it early, you're going to notice more of a steep drop than if you have it, at 55, for instance. So that, it kind of depends. But yes, it isn't the progesterone, estrogen, testosterone sequence that I mentioned before, which doesn't happen for everyone anyway, but that's a very common pattern. If you have a hysterectomy, it's all going to go at once. Okay. Corey is saying, if I've had benign breast tumors and have osteoporosis and mom and grandma had breast cancer, couldn't BHRT help both of these? Okay. Benign breast tumors and have osteoporosis, couldn't BHRT help both of these? So maybe. I would have to know a lot more about your health history and your genetics in order to answer that question. But in generally speaking, benign breast tumors can be from estrogen dominance or toxicity. So you'd want to look at your genes to see whether how you're clearing it. Osteoporosis definitely can be something that hormone replacement therapy can work with. And the fact that there's breast cancer in your family does not mean that you can't go on BHRT, but it does mean that you should definitely see your genetics, what they are, and see what your hormone levels are before, it's a risk benefit analysis. Osteoporosis is not nothing, right? It's a big deal also. So this is where individualized medicine is really important, because you have a complicated situation, and you would really want to evaluate that so that you had all of the information and could decide what's best for you. Okay, what about the pellets inserted under your skin? Are they safe? Are they effective? So They can be safe and effective. They are not my preferred methodology. And here's why. Um, you can't alter anything, right? So if you have an estrogen patch and it feels like it's too much, you can cut it in half with your doctor's supervision. You can cut it in a quarter. You know what I mean? You can put on two if the doctor says, oh, you need to double that, and next time I'll make it a stronger patch, but for this time put on two. You can customize it. You can take different dosages of progesterone. You can take different dosages of testosterone if that's something that your provider will prescribe for you. Pellets are sort of, they're in there, and they're just in there, and they don't necessarily come there. Of course, there is customization. They come in different dosages, but it's not as customizable as some other forms of hormone replacement therapy. So that's not my preference for that reason. Marcy is wondering, I'm wondering why DIM is recommended all the time, yet the person may have the CYP1B1 genetic SNP and weakness in the phase 2 detox, which can cause a bottleneck. Totally. Why is sulforaphane or NRF2 activation not being the safer recommendation, especially in menopause when the person does not want to lower their already finishing estrogen levels? I'm very curious. I actually recommend sulforaphane and things like resveratrol and NAC to use all the time. It really just depends on the person and what their other genetics are. I don't know exactly what's been spoken to in other webinars, but DIM and I3C are good things for some people, and they're not the right things for other people. Just like not everyone should take calcium deglutarate in order to help with estrogen toxicity. It's not the right supplement for them. And I wouldn't necessarily make blanket statements about what people should be doing without looking at them as an individual. So that is my answer. I went from osteoporosis to osteopenia in 6 months on BHRT. Jody, see, we have studies, and then we have real live people coming into the webinar and letting us know that this has been their experience. So I'm curious, what else you did. Did you do strength training? Did you do change your diet at all? I'm always so curious about what people did. If you feel like it, throw that information in the chat. Okay. Perhaps this answer is in your presentation. Once I decided to proceed with BHRT with my healthcare provider, how do I know which form of estrogen would be best for me, cream, patch, etc.? Also, how do I know if I would benefit from testosterone? So it's, for some people, they prefer either what's in a certain form of it or how convenient it is. So some people like the patch because they put it on once or twice a week and they don't have to think about it. Whereas with a cream or something like that, that's typically more of a daily application. Now, for other people, they're going to prefer a daily application because it keeps things more consistent. Whereas with the patch, there can be sort of a ramping up and a slowing down. Some people don't feel that at all. And some people are like, why is it day 2, I feel like this of the patch, and then day 4, I feel like this, or day 3.5 when they change it or whatever. But some patches are for a whole week. So that's part of it. Some people don't care for the adhesive. It may irritate their skin if people are more sensitive to it. And then some people don't like the ingredients that are in the creams. So it really just depends on what's better for your lifestyle, what's better for your body. That's one of the reasons some people like the pellets, because somebody just puts it in and then they get to forget about it until the next time they go in and someone else deals with it, right? So it's very personal what works for people. There are also oils that you put directly on the vagina. There are some creams you put on the arms, some creams you put on the abdomen. The patch generally goes on the abdomen. So depending on whether or not you have other people, some people also prefer the patch if they're going to come in contact with other people. That one doesn't tend to rub off on other people or animals the way that sometimes if you don't let a cream absorb for long enough, so if you're going to do that, just put a shirt on or wait for it to fully absorb. And how do I know if I would benefit from testosterone? If you have certain symptoms of not being able to put on muscle, low libido, things like that, and you test low for testosterone, and that's very important because you can feel that way from other things, and you don't just want to go taking testosterone willy nilly. Um, then that's something that could be an option because women can be deficient in testosterone and feel a lot better on it. Um, the libido thing alone, some people are super into, but really the fatigue and um, not being able to put on muscle that they once were able to put on is also something that sometimes just the progesterone and estrogen don't seem to fix for people. And then it turns out they have low testosterone. But then once again, this is a testing situation. You test and then you retest. All right. Belinda, I had a hysterectomy 24 years ago, had extreme problems with hot flashes and putting on Premarin for a few years and years passing and being lowering the concentration. And now I'm 66, taking 0.3 milligrams twice a week, having a lot of problems with sleeping. What can I do? Okay. So it sounds like you're on Premarin. So I would say get your hormones checked and see if a different form of hormones would feel better to you. Um, that's a definite possibility um, that a different form or different dosage would feel better for you. So I would say try that, but definitely get tested first and just see where things stand. I'm sorry that you're not sleeping. That really not sleeping can really wear on you pretty quickly. Um, Mary, I said, was modifying something above. Okay. All right. Joy. I've heard that if you have a CAC score above 0, that you are not a candidate for BHRT. Is BHRT risky if you have a low CAC score? Um, so I'm assuming that this is cardiac calcium. Yeah. Okay. Just making sure I have my my things right. Yes. So I have not heard that. I wonder if that is because of oral estrogen contributing to potentially blood clotting and things like that. Um, I have not heard that particular thing. Um, so I'm not, I think that since it helps lower lipids, um, that it doesn't necessarily make sense to me. Um, so I'm gonna look more into that and see who's saying that and what their reasoning is because I haven't heard that. Okay. Sheila is asking, is a codominant sex hormone profile a candidate for BHRT? What other genes determine if it is safe for this profile? So the short answer is maybe. Um, Being codominant means that you are both androgen and estrogen dominant together, right? And so part of it is about how quickly you're converting progesterone into testosterone and testosterone into DHT, and how quickly you're converting testosterone into estrogen. But then it's also about clearance, right? So what you want to do is look at all of those things together, how your hormones are being made and how quickly and well they're being cleared down which pathways in order to determine whether or not you're an ideal candidate or whether or not it is poses a little bit more of a risk for you. The other things that you want to keep in mind are overall inflammation, overall metabolic function, um, overall detoxification. So we have to think about not only COMT, we have to think about our methylation. We have to think about our GST family, how we're the glutathione. We have to think about how we're interacting with antioxidants, with SOD and GPX. So What other genes determine it? It's kind of, I don't want to say it's all of them, but it's kind of all of them. So that's why we look at people as a whole. Um, at who is this person? How do they do all of the things that they do in their body, and give you the information that you need to make the best decision that you can. If just starting BHRT at age 63, will I get any cardiovascular benefits around 12 years post menopause? While they do say that you get the best brain and cardiovascular benefits the closer to menopause that you are, there are benefits being shown to starting whenever it is that you can. Is it as beneficial? Perhaps not, but it doesn't mean that there's no benefit to it at all. And I have definitely seen and heard of women feeling better and halting the progression of things by starting later on. So it's worth talking to someone about. I'll say that. Okay. What are the levels considered optimal for estradiol, progesterone, and testosterone for postmenopausal women? There's ranges, but they don't seem to be optimal. Labs have different values for within range. Right. Right. Unfortunately, the answer is it depends on you. People will feel better or worse at different levels. So some women go on BHRT and they feel awesome at 30. And some women don't feel good until they are getting closer to 60 or 80 for estradiol. So so it really depends on what your goal is and what your symptoms are, and probably that is determined largely by your genetics and some of your lifestyle choices. So there are different ranges. It's about the ratio and how you're feeling and what your physician is comfortable with having you have. There are certain levels that are better for bone health. So you don't want to, like, if you're at a 10 for estradiol, it's not necessarily going to help with your bone health. You want to be more in like a 30 or 50 range if that's your main goal, according to what I have read. So so once again, it depends what your goal is. Okay. Shalina is asking, is a Dutch okay for someone currently on BHRT? I'm told it skews results, so I can't get it ordered by my primary. So it definitely changes the results, right? It's going to show you what your levels are on the hormones. And the reason that I still do those with my patients is because, one, I want to know what your levels are on the hormones. I don't want to know what they are off of the hormones because you're on the hormones for a reason. And so I want to know what the levels are. And also, one thing that I love about the Dutch test is that it tells you how you're metabolizing the hormones, what pathways you're taking to metabolize estrogen. And I think that that's a really valuable thing to know. So your primary may not think that it's accurate for certain things, but knowing what your body's actually doing. So there's your genes, which are telling your body what to do, but then there's also what you're telling your genes. So if you're someone who clears down a suboptimal pathway, but you're doing all of these things to correct that, and you do a Dutch test, you can see whether or not it's working, right? You see in real time what is my body's response to the interventions that I'm doing to correct some of my suboptimal genetics. And I think that that's amazing. So that's my bias as someone who likes to know. I like my patients to feel better, but if I can also see that their body is doing the thing that we want it to do, then I feel like that's really valuable. Okay. Now we have Margaret. Okay, this is once again what is an ideal range for serum estradiol. And she has an estrogen toxicity tendency, but her Dutch was in a totally good range. See, this is what I'm talking about. her doctor said she metabolizes the hormones well and she wouldn't need to repeat it, but she thought it was something that women would need to repeat yearly since the metabolism might change. Um, you may be able to go longer than a year. Um, so I'm not going to contradict your doctor, um, because what they're saying is you're doing a good job, so you don't need to worry about it, right? And awesome. You just keep doing what you're doing. If you start to feel different, or if you want to make really sure that your body is still doing what it needs to do, it's not going to hurt you to test again because, yes, the metabolism might change depending on stress levels, environmental toxins. If you change any of your eating habits, if you change how you're exercising, if your body changes how it's responding to any of those inputs, things might change. So just because you're metabolizing it really well today doesn't mean you will be in 3 years. So even if you don't want to do it every year, if you want to do it every 2 or 3 years, just to make sure, that might be what I would do. But I like more data, so that's just me. I'm glad that your doctor thinks that you're doing really well. It's your personal choice. If you're going to keep doing exactly what you're doing with your lifestyle and you're still feeling great, then you probably don't need to test again. But if you're curious or you start to feel different or anything like that, or if you're like me and you just want to double check that everything's still good, then it doesn't hurt for you to test again. All right. Kathy is saying, I have a high platelet count and I've been told I should not take BHRT. Would the DNA test be helpful to determine if I can take BHRT? So what they're concerned about with BHRT is, I understand the concern there. I think that the DNA test would be helpful, to see how your body processes it, but they still may not feel safe putting you on something. When people have had a history of strokes or blood clots or things like that, and you haven't, I'm not saying that, but there are certain things that that physicians tend to be concerned about prescribing it just in case. They want to be more cautious, because no one wants to hurt someone, right? So um, I don't know as the DNA test could definitively say, yes, you can go ahead and take it, but it could definitely show you how your body tends to clear things. It could show you what your endothelial tissue is like, if it's really sensitive to inflammation or not. It can show you what you're likely to do in response to cholesterol, how you're detoxifying things in general. So I don't think you can take the test necessarily to the doctor and have them say, look, this is my gene test. I can take BHRT, because I think that they're going to, they might be worried, but it's not that it wouldn't be helpful for you for other reasons. Okay. Barb is saying, my doctor claims that I don't need progesterone because I have had a hysterectomy, but my other doctor thinks I do need it. They are both hormone doctors. One is pellets, one is shots. So the doctor who's saying that you don't need it, I think what they're saying is it's not dangerous for you to take estrogen without taking progesterone, because progesterone helps protect the uterus from having from having your lining get too thick and perhaps becoming precancerous, right? So the progesterone helps protect the uterus. That's why everyone always says, if you're taking estrogen, you have to take this dosage of progesterone for this number of days as a minimum, right? But there are other reasons why one might take progesterone. So progesterone is relaxing. It helps with sleep. It actually helps with inflammation. There was a great study all about how progesterone affects the entire nervous system from the spine up to the brain. So they are both right in terms of how they're thinking about it. I'm curious why the doctor who thinks you do need it does think you need it. Maybe you're having some sort of symptom that feels to them, that seems to them more progesterone related. That would be my guess. So there's need and then there's need, right? It's two different reasons why they're saying that, if that makes sense. Okay. Next we have Alvan. What are your thoughts on physiological restoration, including the use of rhythmic progesterone? What would be the best time to test hormones while on BHRT? Appreciate it. So what I don't know is if you are still menstruating or if you're not menstruating, and whether or not you're doing rhythmic cycling of progesterone. So that makes it hard for me to know the best time for you to test your hormones. If you haven't had a cycle in a really long time, then you can just kind of do it whenever. If you're going, so other, if you're perimenopausal, it's actually best to kind of do it at two different times, which no one wants to hear. But if you do a test on like day 2 of LH, FSH, and estradiol, and then do another test on roughly day 20, 21 of your cycle, depending on how long your cycle is. So this is all sort of assuming a number of things. That's when you would want to do your progesterone. And I would suggest doing estradiol again at that time. So hopefully that's helpful with the information that, oh, and thoughts on physiological restoration. I think what you mean by that is resuming the period. For some people, those levels of hormones are exactly what they need. They feel awesome. And some people are like, seriously, I had my period for this many years. You're not making me go back to that. And it's not necessary, in my opinion, to do that in order to get the benefits of BHRT. So it really depends on the person and how they feel about menstruating again. That said, you can take progesterone part of the month, even if you don't return to having your cycle. You can do that just to do that, and it doesn't mean that you have to return to having your period. Some people do only take the progesterone for 2 weeks out of the month, and that's a non-issue. And some people feel better taking it all month. And this is once again where it's very bio-individual. And having someone who takes you into account and doesn't just do it the same way with every single person, I think can be really helpful, because you're not like just every other person, right? All right. How can your genes, which are the same throughout your life, influence your hormone production, which varies depending on your age? That is such a great question. I mean, all of these are great questions. So, how you respond to the hormones that are made in your body is going to be consistent, except for your lifestyle, right? So, they influence your hormone production because there's a certain way that they're giving the instructions for your body to respond. But how your body responds also depends on where you are in your life. So if your body, for instance, is producing a ton of progesterone and converting it slowly into testosterone, at some point, you're going to stop ovulating and you're not going to produce a ton of progesterone. But it's not because of your genes, it's because of your ovaries and their connection to your brain and that whole interplay there, right? They are still, when you start to develop symptoms in perimenopause and menopause, how all of that goes for you is still determined by your genes. But it's not just one set of inputs. I'm trying to think of an example. So, so I have this glass and I have my wonderful DNA company water bottle. How much water I start out with in here determines how much I can put into the glass. But how big the glass is also determines how much water I can put into the glass. Do you see what I mean? Like, both of these things are going to affect how much water ends up in this glass. So it's not just what I started with, and it's not just the container that I'm putting it into, it's both. So hopefully that made a little bit more sense. Okay. Can you state the letters that we see in our results rather than just say fast or slower? Oh, kind of late for this one. Um, my apologies. Um, if I can circle back to this at the end, I'm happy to do that. I'm really sorry that I didn't see it earlier. I will try and do that on the next webinar. Okay. Or I will do that on the next webinar. I won't just try. If your Desiree is saying if you're estrogen dominant and on BHRT, progesterone, estrogen, testosterone, how do you know if you need DIM or calcium D-glucarate? If you're a fast CYP17A1, does that impact whether or not you need them? And the answer to that is all of the genes are going to impact whether or not you need them. So CYP17A1, for those of you who may not remember, this is about converting progesterone into testosterone. And so if you have I'm gonna do it now. If you have AA as the letters afterward, you convert them into in a balanced way. That's like considered middle of the road. If you have an AG, then you have increased conversion, and you will have a more dominant androgenic profile. And if you have GG, then it's definitely an increased conversion. So that's where that's a more extreme version of the increased conversion. So in terms of DIM and calcium D-glucarate, if you then convert the testosterone that you've converted quickly from progesterone into estrogen, that would be the time when you would be thinking about DIM and calcium D-glucarate. Calcium D-glucarate is specifically if you have too much beta-glucuronidase in your intestines. So it's not just something that's not necessarily how you want to get rid of extra estrogen because of the other things that it gets rid of at the same time. There is a time and a place for calcium D-glucarate, but it's not just if you are estrogen dominant. It's if you're estrogen dominant, and it's partly because, and then you're also not, you have too much of the enzyme that brings it back around, back into your system instead of excreting it. And in terms of whether or not you need DIM or sulforaphane or something else, it would be based on your pathways. So you'd want to take a look at CYP19A1, CYP1A1, CYP1B1, CYP3A4, and just see what those are doing and see what supplements might be best for you. Okay. Okay, I think I already answered this question about what it would need to be to protect bone density. I already answered that one. Okay. How long do I have to take BHRT before I can see measurable results? Based on my Dutch test, I started taking this 10 months ago, primarily because of my osteoporosis. My latest bone density test doesn't show improvement. It still shows deterioration compared to previous years. So I would say to get a blood test and see whether or not you need more estradiol and perhaps more progesterone. That just may not be enough to get your blood level to the place that it needs to be in order to halt the breaking down of bone. And I'm also not sure if you're going someplace to get some help with strength training and things like that. So, or if you've changed anything about your diet or anything about your lifestyle. This is why it's hard for me, because I'm happy to have all of you as my patients, but right now none of you are my well, I'm going to say none of you are my patients. So it's hard for me to answer a specific question like that. I would get a test done and see what those levels are, because it may not be that it's not working. It may just be that there isn't enough of it yet. Okay. Okay, once again, wishing that I had said the letters. I'm so sorry. I think that my what I was thinking is that in the app it would say fast or slow, or optimal or suboptimal. So my apologies. How reliable is the Dutch test? Well, the Dutch test is very accurate for what it's doing. If you take it on the wrong day, meaning not at the right time of your cycle or things like that, then you might not get the result that you want. Um, if you take it right after you've taken hormones or too late after you've taken hormones, you may not know what the, if you wait 24 hours or something like that, progesterone clears out of your oral progesterone, metabolizes really quickly. So it will leave your system within hours. Whereas estradiol, it takes longer for that one. So it's a complicated question. It is validated to do what it says it does, and typically, things like Mira and the Dutch are showing what was in the blood about 24 hours before. So it's like this is what was in the blood the day before. So that's why sometimes a blood test and a Dutch test or Mira test can look different, is because if you looked at the blood test and the urine test the next day, they might look more similar. And that can make a really big difference if you're still ovulating and you're trying to see what your progesterone levels are, because that can be very different from one day to the next, because progesterone can in some cases kind of go whoop, like all the way up right after ovulation. It does go up exponentially. So I hope that was helpful in terms of answering your question for how reliable is it. I know that some people don't love the Dutch test. They really prefer Serum. I actually like both, and I like Mira. So I find that it depends what it is that I'm trying to accomplish with the patient, where they are in their life, where they are in their in terms of being premenopausal, perimenopausal, postmenopausal, that I will utilize all of these tests just at different times of someone's life and different times of the cycle, if that makes sense. So, wow, we got through all of the questions. I'm glad that I started early, or I would not have. So I'm going to take a minute to just go through these hormones and tell you the letters that you were wishing I had told you earlier. Okay. So with CYP19A1, CT is sort of average. CC is decreased. So that's you're not going to convert testosterone to estrogen as quickly. And with TT, you will convert it more quickly. All right. I just went over CYP17A1, SRD5A2. If you have CG, you have a regular conversion of testosterone into DHT. With CC, it's a decreased conversion, and with GG, it's an increased conversion. So you'll have more of the super potent testosterone. UGT2B17, that's a copy number variation. So if you have 1, that is average. 0, you have a decreased metabolism and clearance of androgens. And with 2, you have an increased metabolism and clearance. UGT2B15, GT is normal clearance. CC is decreased clearance. TT is increased clearance. CYP19A1, CT is average aromatase activity and conversion of testosterone into estrogen. CC, it's decreased, and TT, it's increased. So then you'll see more of the estrogen characteristics. CYP1A1, GG, is increased metabolism of estrogen into 2-hydroxyestrogen. AG is still increased, and AA is decreased. CYP1B1, CC is decreased metabolism, which is preferred. CG is suboptimal, and GG is definitely also suboptimal. but there are things you can do. And finally, CYP3A4, AA is preferred with a decreased metabolism into 16-OH. AG is suboptimal and GG is suboptimal. And we're still going to finish on time. Thank you all so much for joining me this evening, and for all of your great questions. And I will see you again tomorrow when we talk more about hormones, specifically about women's resources, what resources you have out there to help you get through whatever phase of life you're in. So tell your sisters and daughters and mothers and everybody to come on down to the DNA Company webinar tomorrow night, and I will see you there. Thank you so much.